thank you very much. And I'd like to say hello from Wollongong, Australia. And it is afternoon for me on a beautiful sunny afternoon in Wollongong. And I'd like to say hello to our Irish friends. And it's morning and it's cold. And this is where we are, and this is the home of Peacock Australia. And these are some scenes that explain why I live in Wollongong and why Wollongong is the lead agency for our National Palliative Care Outcomes Collaboration. And we want to say a special hello to our friend Martina and point out that Hymes Beach on the bottom of our slide, which is said to have the whitest sand in Australia, was the place that the palliative care team from Ireland came last year after they'd been with us at the conference. What I'm going to do today is three things. I'm going to first of all talk about some ideas about why we should measure outcomes and what is an outcome, so some of those concept ideas. The second thing I'm going to do is show you some data, and today we have some Irish data. Irish services started participating in Peacock last year, and so this is the first time we've got to demonstrate some Irish data, and the third part of what I'll do then is draw some conclusions. Why we're going to measure outcomes is essentially because I don't think we've got a choice. We can no longer say that a drawer full of thank you letters is enough. We have to, as policy makers and as clinicians, demonstrate what we do. And if we don't measure outcomes, if we don't actually have measures of the outcomes of our care, then we inevitably open an invitation for people only to talk to us about cost and technical efficiency, how cheaply we can do things and not whether they're worth doing at all. So outcomes are really important because we want to move the debate from being about cost to about value for money. And we want to, as a country, as Ireland does, demonstrate that palliative care is an investment and not just a cost. And that for us is really fundamental to the future about how we plan our healthcare systems, because we should not be investing in things that are not valued. So what's an outcome? Well, it obviously depends on who you ask. And the first time I was ever asked to talk about palliative care and outcomes, we all made jokes about the obvious outcome is death, but of course that's not right. An outcome is a change that you can attribute to an intervention, and I'm going to return to that. But I do want to make a point that through the eyes of patients, providers, families and payers, they will all have different perceptions of what an outcome is, and we need to understand and capture the most important of those. And I don't intend to walk you through this slide other than to say that there are a mix of very basic measures, pain and symptom control, but also really important issues like time and families wanting a sense that everything possible is being done. And I think for providers, there's also a real focus about meeting needs in the most efficient way for the patient in the right place. And I'll return to that at the end. So an outcome in palliative care or in any other care is a change in an individual or a group of individuals that you can attribute, at least in part, to an intervention. And I really want to pick up three key ideas, but before that I want to make an obvious point. A health outcome is not the same as health status. Around the world, rich people have the best health status, and this is not because of the care that they get from health systems, it's because of their wealth, their education, that they live in all the best areas, etc., etc. So we need to understand that we can't just say a health outcome is health status, and we really need to distinguish between those two concepts. So a health outcome is a change, and that means that there's at least 2 points in time that you can attribute either directly or by program logic to an intervention, and that means we actually understand what somebody delivers. And the way that we've typically thought about outcomes is before and after. I turn up at the hospital with a ruptured appendix and they take out my appendix and I go home, or else I die because I didn't get the right care. But either way, a health outcome is really simple. It's an acute care paradigm where somebody starts off unwell and then they end up well. And that's the way that traditionally clinicians have thought about outcomes. And that model does not work in any areas of chronic disease. It doesn't work for people with protracted illness with schizophrenia, or people who are diabetic, or in fact people at end of life. So we need a more sophisticated way, and the way we think about that is what I'm calling with and without. A health outcome is the change that we can attribute, at least in part, to the intervention that the person got from the palliative care service. So that's the difference between getting no palliative care or getting palliative care from somebody else. And that's outcomes for both patients and carers, and that is the fundamental basis of our Peacock model and also the two other national outcome centres we run here at ASRI, which is the outcome centres in rehabilitation and persistent pain. We're interested in how outcomes for patients compare to if they receive no rehabilitation or no palliative care or no pain care compared to either no care at all or the services provided by somebody else. And here I want to introduce another concept, but before I do so, I'm looking for volunteers, as I have been for the last 30 years, for my randomised controlled trial on parachutes, because 30 years ago, we all started talking about the randomised controlled trial as the gold standard, that the only way we could do research in health, that nothing else was valid other than the double-blind randomised controlled trial. And on that basis, we have no evidence that parachutes work. So for 30 years, I've been looking for people to join me. I've been recruiting for my double-blind randomised controlled trial because I actually want to know whether parachutes work, because I know that I can't test it in any other way. And I want to call that concept efficacy. And I want to distinguish between efficacy, which is what we do in a randomised controlled trial. We test a new drug, we select the patients, we carefully measure the dose. We don't accept patients who are frail, old, young, with comorbid conditions. We carefully select the patients, we test the intervention, and we agree in a randomised controlled trial whether the people who got the intervention do better than the people in control group. The problem with efficacy is that it's not a good measure of effectiveness. So effectiveness is not what happens when you perfectly select the patient, it's what happens when you then take that drug or that intervention and give it to children and give it to old people who've got multiple comorbidities, and you get a totally different result. So efficacy is the level of benefit you get when you can carefully train clinicians and apply an intervention under ideal conditions to selected patients. And effectiveness is what happens in everyday practice with everyday clinicians, with everyday patients. And Peacock measures effectiveness. The reason we exist is not to do randomised controlled trials. They are still really valid, and at the end I'll keep asking if anybody else in Ireland wants to be in my randomised controlled trial. But until then, we need to understand that some research questions are best measured through a randomised controlled trial and some are not, and we need to be much more reflective. So here at ASRI, as part of Peacock and the other centres, we're much more mixed methods of trying to select the right measure for the question of interest. So Peacock is not a research project. The goal of Peacock is to improve care that patients and families receive, and we do that by wanting to change clinical practice. And the way we do that is that we have a set of patient-reported measures. We also have clinician and carer-reported measures, but PROMs, and we want those measures that we have developed or collected to be applied at point of care with every patient every time they're seen. So that's daily in an inpatient unit and at every home visit in a community unit. And as a byproduct of delivering that care, we want to use services outcome data to systematically measure the outcomes that they're achieving and identify opportunities for them to improve. So the traditional logic, when I was taught quality assurance 40 years ago, it was process improvement drives outcome improvement. We're going to measure our process through accreditation, quality assurance programs or the like. We're going to measure ourselves against standards, and we're going to identify things that we can be improved, and we're going to assume that if we've got good process, we automatically achieve good outcomes. And if we can improve our process, we also automatically assume that we've actually got better outcomes. Peacock turns that logic on its head, and Peacock says outcomes drive process improvement. We're going to measure outcomes and we're going to use the outcome measures to identify areas where we think we can improve practice. And that's the same approach across our 3 outcome centres. And this is really an outcomes-driven reform where we're listening to patients and we're using what they tell us as the basis of improving our care. So the unit of counting for PCOC is really important. It's not from referral to discharge, which is what you would use for a surgical episode, because in fact the majority of patients will die. We're talking about patients who have 1 or more episodes of care. They're defined by setting, where a patient might be in hospital or they might be at home, or in fact they might have an ambulatory episode where they're attending an outpatient clinic. And each episode consists of phases. So these are the stages of illness. A patient will be either stable, unstable, deteriorating, or terminal. And in fact, we also have a 5th phase, which is bereaved after the patient has died, and we are providing bereavement support to the patient's family. And the outcome is the change from the beginning to the end of each phase compared to comparable patients seen by other providers. And on average in Australia, we have about 2.5 phases per episode. And that hasn't changed really over the last 15 years. And we can bundle phases to look at episodes, and we can bundle episodes to look at patients. But when I show some results now, I'm going to be talking about phase level data. So here's some numbers to start with and some outcomes. So this is really exciting. This is the first time that these have been shown. This is PCOC Australia and PCOC Ireland for the first 6 months of this year, so the period January to June. And in Australia, we had 29,000 patients, 30,000 patients in our data set that I'm about to show you. And in Ireland, we have 19,000 patients. And to put that into perspective, that's about, for Australia, we have about 80,000 deaths in the first 6 months of this year, and we have 30,000 patients in our PCOC data collection. So it's quite a high level population coverage. And for the Irish collection, it's about 9 or 10%. So for the first ever collection, they're very important measures to have, and these are not trivial numbers. So here's my first piece of information that's a really important piece. This is patients, as I said, have phases, and at each phase, at the beginning and the end of every phase, we measure symptoms, and we measure both symptom severity, which is a clinician-reported measure, and symptom distress, how distressing the patient finds it, and that's the symptom assessment scale, or the SAS. And across these various measures, the proportion of patients with moderate or severe distress is double the rate in Ireland than it is in Australia. So if I use the very first one you can see, which is family carer distress, 40% of families in the Irish data set are reporting moderate to severe problems compared to less than 20% in Australia. And that reflects 2 things, I think. One is we've been going for 15 years and Australia has improved outcomes by some 30% during that 15 years. The second is that the Irish profile looks almost the same as the initial profile of all of the services when they've joined in Australia over the last decade. But I want you to keep in mind that the percentage experiencing problems is double in Ireland when I now show you the rest of the figures. We have 2 really important concepts, and one is responsive care. So these are for patients who are reporting moderate or severe problems at the beginning of their episode, and our goal is that by the end of that phase, they are now reporting no problems or very mild problems. So that's responsive care. And this is what Australia looks like over the last 10 years. When we started this work, for those patients who are having problems in that domain, and I'll use fatigue, which is the bottom line in the red. In 2009, only 15% of patients reporting severe distress from fatigue actually had that resolved by the end of the phase. And now we are up to 50% across the country. And that, as you see, is a very progressive journey. So when I show you that the profile in Ireland is that patients are much more likely to be reporting moderate and severe problems, the Irish patient profile is much more like Australia was back around 2012-13. I also want to talk about fatigue to make an important distinction in some concepts. You can't change fatigue. That is actually part of dying, and we all understand that. But you can change the distress that patients feel about that fatigue. And so we have the SAS in our collection, and it asks patients about their distress. It doesn't ask, how tired are you? Because that's not an outcome, that's a measure of health status. We ask, how distressed do you feel about your fatigue? Because that's the outcome we can do something about. So that's responsive. And the second concept is anticipatory. We don't want palliative care services just to focus on the problem patients. We want them to be equally focused on preventing problems developing. So these are the patients who start a phase with absent or mild and who end, and we want them to stay that way. And these are our anticipatory outcomes over a decade in Australia, and you'll see now that we have had significant, and one I mentioned before, it typically 20 to 30 and in some cases a 40 percentage point improvement across Australia on 40 to 50,000 patients a year. We don't need a randomised control trial. We don't need a parachute trial to tell us that we are very confident about the results we're now reporting. Another of our measures in our data set is the unstable phase and the percentage of patients who are stabilised within a couple of days. So the unstable phase is the most distressing phase for patients and families. It's very scary. Something's happened that nobody predicted. Either the patient has developed a new problem, or an old problem's got much worse, or the family has developed major problems. And our national benchmark is that 90% of patients in the unstable phase are out of that phase within 3 days or less. When we started Peacock, it was 5. As soon as the whole country met 5, we raised the bar, and now it's 3. So that's what an unstable phase is, and this is what our results look like across the country. And the bottom line is community palliative care, which is the focus of this conference. And here's a headline on almost all the slides I'm about to show you. Patients at home receiving care have much worse outcomes than patients in hospital. And that is the case in this unstable one. But I think the other thing I would say about this one is there is no question about the significant improvement we have achieved in this outcome in Australia. And I know that the Irish have been really focusing on that. The big 3 services that are the first phase for us. So here is the blue wave in the background. A couple of hundred palliative care services across Australia, and the services up in the high end, that's all the services that are now achieving 100% on that measure over 6 months. They didn't have one patient still unstable after 3 days. But you'll also see we have some patients down in the very low end still, and you'll see as well 2 numbers on this graph. 94% of inpatients in Ireland are stabilised within 3 days, and 53% of Irish palliative care patients being cared for at home are stabilised within 3 days. And as I said, I don't want Irish services looking at this to be discouraged. We've been doing this for years, and it's actually room for really big improvement. Just like some of our low-performing services, we're still working with them very much. Here's our second measure, and this is our only process measure, and this is that the patient receives care within 2 days of being ready for care. And across the country, our national benchmark is that 90% of all patients should be in receipt of care within 2 days of referral. And across Ireland, 91% of inpatients are receiving care within 2 days of referral, compared to 83% for community patients, and the Irish community percentage is actually above the Australian. That's our only process measure. All of the other measures are about outcomes for patients, but clearly anxiety significantly increases when timeliness isn't there. And I think that raises another issue I want to raise about benchmarks. We set benchmarks through the eyes of patients, not through the eyes of services, and we have a lot of 5-day services in Australia, community services in Australia, in rural and remote Australia. And we made a decision, they made a decision, that we were going to have the same benchmark for teaching hospitals, community hospitals and remote nursing stations, whether in the public sector or the private. And the Irish colleagues we've been working with have adopted that same approach. Here's the next measure. This is anticipatory care and its pain. Across Australia, you'll see the wave. Again, a couple of hundred services. For Irish inpatients, it's 81% of patients who are pain-free staying that way, and it's 78% for community palliative care in Ireland, which is actually above Australia again for community by a little tiny bit. This is responsive care. You'll see a much bigger variation in Australia, and we've been doing this work for 15 years now, and we've improved outcomes overall, but we're still addressing the fact that we've got some services right up at the 95% mark and others doing right down. And here we've got 50% for Irish community patients and 39% for Irish inpatients, which is well below Australia and well below community. And we think that's about what happens when you focus too narrowly on meeting one benchmark, which is unstable phase, at the expense of others. You really need to have a balanced scorecard, and we're really focusing on working with services that they can't just be good at one thing, it's about being good at everything. This is anticipatory care for fatigue, and again it's the distress from fatigue rather than the severity of the fatigue. Both services in Ireland below and at the bottom end of the Australian data. This is responsive care for fatigue. Again, both services well down for the Australian data. And I guess that would bring in some bit of evidence of what you measure matters. And we have had major improvements. It's been the symptom we have improved most since we started benchmarking. Anticipatory care for breathing problems. Really good performance for everybody of preventing breathing problems developing, but not very good achievement on and responsive yet, but we're getting there. But very close for the two Irish groups that we've got on the graph at 41 and 39%. Family carer problems. This is the one that's always really surprised community palliative care providers, and that is that we have consistently found that both patient psychosocial distress and family carer distress is much worse for patients at home than those in hospital or in hospice. So this is 82% for Irish inpatient services and 56% for Irish community services. And this is responsive care, the ability to deal with and support families once they're in problems. And I think that raises where I want to move. I don't want to really talk about any more data, but we have a lot more. But the patterns are very consistent Overall, I think our outcomes, as the Irish outcomes, are actually very good. We should be really proud of that. We should also understand that there are many things we can do to improve, and that we have been working with services now continually for 15 years and we still haven't plateaued in terms of improving outcomes. I do want to, though, talk about this outcomes gap, and I think the real question for us is, can you close that gap? And I really want to make a point that one of the things we emphasise all the time in palliative care is about how important choice is. And a lot of patients, most patients and most families say to us at the beginning of palliative care, I want to be at home and I want to die at home. And we understand that. We also understand, though, that elections change as that journey progresses. And I would also be arguing that just like you need to understand the evidence to make a choice between two surgical interventions, palliative care patients and families have the same right to make informed choices about where they want their care to be and who is best to manage particular problems at a particular point in time. So these are our results. Overall, adjusted for phase and all the other things we can adjust for, patients who die in hospital are 51% more likely in Australia to have no severe problems at all just in the period before death compared to patients being treated at home. Many patients will still elect to be at home for all sorts of good reasons, but it's really important to understand that that's quite a big gap. And that odds ratio of 1.5 is really quite important, I think, both clinically and statistically. This is just severe symptoms now, and it's only Australian data. And you'll see on one side we've got hospital and on the other side we've got home, and we've got the percentage of patients reporting severe problems at the beginning of their episode of care and the percentage still reporting severe problem just before death. That is when the phase changes to terminal. Two observations. One is hospices are actually accepting the right patients in. Patients are much more likely to have severe problems, and hospitals have very few people with severe problems by the end. Compare that with community, where in fact for that severe percentage it's very small, but it actually goes up overall. These, don't forget, they were very small percentages. Look at the axis. The axis is from 0 to 8%, which is quite low and much different to the perception of people's, and this is only for the severe group. The second I'd want to say is that outcomes in Australia have improved significantly in that 10 years, and they've improved both statistically and clinically significant changes, and we've published numerous papers on that. I'm sure most people would have read. But I think the most important thing to say there is the gap between our inpatient services and our community services have really not changed. When one improves, so does the other. And I always refer to that in the graphs as the train tracks. The train tracks just stay the same bit apart. The only thing we are seeing is a little bit of train track improvement in pain. They are coming a bit closer together. So there is a really big question for me about how do we conclude about 10 years of improvement when they're improving at the same rate. The third is that even when we take that subset of services, very well funded, Ireland, we have some services that are really well funded and others that are really poorly funded. When we take just the best funded services, their outcomes look very like an average inpatient unit. It's not just resource, although that is really one of the critical factors. So what have we learned? The first one is this: in God we trust, all others bring data. I did make an anonymous Treasury official in 2025, so I've got 5 years to get there, but I do think it comes back that ultimately a drawer full of thank you letters isn't enough. We have the means now to put the outcomes on the table and to demonstrate how important it is. But this is what we've learned. One of the things we've learned is that simply giving teams back their own data does not drive improvement. Every team has members who come to work every day believing that they're doing a good job, and services are generally quite surprised when they find out that somebody down the road from them is doing better. And it's not that they're not trying hard and all those sort of issues. That they don't automatically know what to do. So over time, we've developed a set of tools, assessments, protocols and capability frameworks, and we do peer-to-peer benchmarking and community of practice and a whole lot of other initiatives helping services, equipping services with the tools to improve. My next conclusion is about best practice care, and that is that best practice in the future is about genuine options for patients and families. Not everybody wants total 100% pain control at the expense of everything else. But we need that every patient and every family has that option, and that we're really clear that there are no wrong choices as long as it's an informed choice. So genuine options are about accessible, high quality care, and is in an aged care, in hospital or in their own home. The second key point I would want to make about that is that this is all now about seamless care and seamless movements between hospital and home. We now have a number of community services who routinely say to patients, on average it takes us 5 days to stabilise somebody who's developed this problem, but we can admit you to hospital with the goal of getting you home within 48 hours. Would you like to stay at home for 5 to 7 days, or would you prefer to go to hospital for 48 hours? And we will actually make that a smooth pathway for you. That, for me, is best practice. So that's about shared health records, particularly that are now possible because of our electronic environment. It's about impeccable team communication, and it's about using a common language. And most of our, I think a big change that we've achieved in Australia is that referrals now, I'd like to refer you to this patient, they're unstable, they've got a SAS of 9, etc., and it's become the common language, what we would call palliative care vital signs. It's no different to taking a blood pressure or a pulse. These sorts of measures are palliative care vital signs. I think the other issue I'd want to say is that we're really clear now that the best practice care is patients and families being in the right place for them at that time, and that where our role is to actually make that possible. And that might mean lots of movements between settings of care, if that's what's right. And the same applies for dying. There isn't a right place to die. So the policy implications as well as the clinical practice implications are very simple. Funnily enough, there is no wrong place to receive care, and there's no wrong place to die. And I read a lot of policy documents in Australia. We've got a bit of a purge of them at the moment, which is all about everybody wants to die at home, and our job is to make sure that that's possible for everybody. Win-win, it's cheaper for us and better for you. I think we're starting to really revisit that. Right care, right policy is that we have the range of options on offer for everybody, every day. The second point I want to make about that is that we need to really change our thinking, and we need to focus on preferred place of care rather than preferred place of death. We don't capture preferred place of death in PCOP as a routine item, and we have resisted that for exactly this reason, but we are about to do a one-off study capturing preferred place of death at referral to palliative care and at the beginning of the terminal phase to try and understand how elections have changed. My next conclusion is that even though we've been going 15 years, there's still more to do. And if somebody had told us 15 years ago you'd still be doing this, I wouldn't have thought I would be still doing it, but if they did, and that we have improved outcomes year on year for 15 years and we haven't plateaued yet, we would be quite astounded. But that is actually the situation in Australia, that we have no evidence that our outcomes have plateaued. We have only now about 3 or 4 specialist palliative care services in Australia that are not participating in Peacock. We've got a big rollout at the moment into general practice, into aged care homes as well, and into acute care as well. And we're interested to start to compare outcomes for them too. And that really is the second dot point on my slide. We're really interested now in moving to a population approach to be able to draw conclusions about palliative care, about end-of-life care for people in Australia as a whole. We are now reporting, in a country with 160,000 deaths, we're now reporting 40 or 50,000 patients a year. We have 60,000 patients who die in aged care homes. That would be our single largest group. We don't have in scope, although this year we will have 5,000 of those patients in by the end of this year. So that's progressive for us. And we're very interested in doing international benchmarking about how our outcomes at a population level as well as at a service level compare across countries. My final slide is this one, and that is that we have worked really well with our Irish colleagues, and Martina O'Reilly at Milford is really happy if people want to contact her about joining in with us. It's been a great collaboration with Ireland, and we look forward to that collaboration continuing into the future. Thank you very much, and I will be available to take questions and answers and to join in the panel. And I'll finish by thanking the organisers for inviting me. Thank you.